This is the Work Smart Hypnosis podcast session number 198, Garry Coles on hypnosis for cancer patients.
Welcome to the Work Smart Hypnosis podcast with Jason Linett, your professional resource for hypnosis training and outstanding business success. Here's your host, Jason Linett.
Once again, Happy New Year. As we said last week here on the program, it's Jason Linett with an amazing conversation, this time with Garry Coles, directly over from the UK. I first met Garry by way of the HypnoThoughts Live convention, got to briefly hang out recently at the UK Hypnosis Convention, and it's about time getting him on the program. And you're going to hear an incredible story in terms of initially doing some training, finding some skeptical yet profound results from the hypnotic process, and kind of stumbling into a specific niche market of working with cancer patients. The whole story of that really was a market that found him, and then finding here are the ways to go about doing it, and an amazing conversation in terms of looking at how the educational process was, at least at one point, over in the UK, actually being able to go through a master's level education through a university as a hypnotist, a program which unfortunately doesn't exist anymore, but there are some pioneers helping to restart such a thing. So inside of this conversation, there's going to be some takeaways around looking at how do you define what specific markets you work with? How do we communicate differently in different styles from one market to another? How do we really work to properly build a business inside of the medical model as a completely complementary integrative service as opposed to being something so far off to the side? The whole mindset, as we're going to talk about here, of really being the peer within that environment rather than just the vendor who's coming in trying to offer something entirely else. Just some really cool takeaways inside of this conversation. The links to Garry's website are, of course, going to be over on the show notes at worksmarthypnosis.com. We'll also link to his upcoming pre-conference, I believe, class that's going to be happening at HypnoThoughts Live 2019, getting into some of the more release hypnotherapy streamlined techniques, as he's going to talk about here in this conversation. And if you're really looking at the aspects of how do we work with people going through medical situations, this is a conversation you really need to hear. Also, while you're online, of course, it's coming very soon. Head over to worksmartbusiness.com, which if you're listening before the book launches, heading over to that site is going to give you access to a digital copy of the book before it launches. If you're listening after the book launches in late January, that's going to redirect likely over to the Amazon website. We can get a copy of the book over from there. It's basically taking my entire journey as a self-employed business person, an entrepreneur, and from the whole premise that if I can do these things that I've done in this hypnosis community, in a field where oftentimes we have to convince people that we're not going to make them cluck like a chicken and all these other things, to take the same knowledge, to take the same journey and bring that out to a much larger business community, other folks can replicate that success even greater. And while not necessarily a hypnosis book, it is entirely a chronicling of what I've done to build the hypnotic business empire that I'm now operating. So check that out, worksmartbusiness.com. And with that, let's jump directly into this conversation. This is session number 198, Garry Coles on hypnosis for cancer patients.
Mine is quite an unusual one, I think, compared to a lot of other people. Most hypnotherapists I meet, they always have this idea of I want to help people and I want to do this, and I always had a great hankering to do it. I'm almost the complete accidental hypnotherapist. I think that I suddenly found it was something that I was very good at. The whole story behind it is up until about 19 years ago, I had a completely different career. I was an IT consultant in the oil industry, probably about as far removed from hypnotherapy as you can get. I ended up, due to circumstances, company being sold, ended up being made redundant, but not in a situation where I had to find other work to do, particularly quickly. So I had no idea what I wanted to do, apart from the fact that I quite fancied working for myself. It was around this time of year, interestingly enough, and I thought, okay, Christmas time's coming up. I'll set up a web store to sell books for Christmas. I needed some sort of income, so I thought I'll set up a web store, sell books. I did that for Christmas. January came, and I thought, what do people buy in January? and I had no idea. And suddenly somebody offered me a job lot of weight loss and quit smoking hypnotherapy CDs, and they sold incredibly well. And that sort of pricked my ears up a little bit to thinking, well, actually, I didn't realise it was quite as popular. But I was still quite sceptical at that stage about hypnotherapy generally anyway. But I thought I had books on it, as you do as a teenager, that sort of thing. So I thought I'd go back and investigate my books. And then I saw a local doctor of psychology, who was also a hypnotherapist, offering an introductory course in it. And I thought, OK, I've got plenty of time, plenty of money. Why don't I go along, have a look at that? Perhaps it's something I can do on the side, which is something I now get very irritated about when people do that. But so I went along, still being quite sceptical. And one of the things that the doctor said was that if anybody's got any issues, as part of the course, we're going to resolve them. And I didn't, as far as I'm concerned, I had no real issues. But the only thing that had been a problem, if you could call it that, was ever since a kid, I used to have nightmares several times a week, to the extent that I'd wake up sort of punching, shouting, that type of thing. But it never bothered me because it was normal. I'd been like that all my life. But the doctor said, OK, we're going to work on that. So we did a lot of hypnotherapy work, and I thought it was rubbish, to be honest. I was very unresponsive. I don't visualise very well. IMRs didn't work. Just about everything he told me would happen didn't. And at the end of our sessions, I said, look, out of respect, I said, I was sitting there with my eyes closed, just following along, but I said, nothing happened. And he said, OK, let's just see how it goes. And I think it was about 6 weeks later when I realised that I hadn't had a nightmare since. So I thought, OK, there's got to be something in this, so that warrants investigating a little further. So then I decided to do a diploma course with him, and we took off from there. We took off with the diploma course, again with the idea of perhaps doing a little bit on the side. And again, so I did that, and everybody was saying to me, well, the big thing now is you need experience. And that's the difficult part to get because you've got no clients. So if you've got no clients, you're not going to get experience. And then I was contacted. I've had lots of things that have sort of fallen into place rather strangely in my journey, because I was contacted then by our local hospital, or in particular the cancer unit. And they said, we just understand you've just qualified as a hypnotherapist. We use them as volunteers in the cancer unit. It can be very effective, but our ones have just left. Would you like to volunteer some time to us? And I was, at the time, sort of thinking along quite a mercenary line, if you like. I was thinking, OK, yeah, I could go in there, see 8 patients a day. My experience will go through the roof really quickly, and then I can just disappear. It'll be a nice experience. I can go off, make lots of money, and so on. So I went into the oncology unit, started working with the cancer patients there, and 14 years later I'm still there. So this idea of disappearing and doing stuff didn't materialize in that way. Obviously I see a lot of clients do a lot of other stuff, but giving up that has never happened. And that's sort of come full circle in lots of other ways that we'll come sort of onto later.
Yeah, and I'd love to kind of rewind back inside of that, because there's so many things to elaborate upon there. That I love the idea that, from that initial start, and I'd share a similar through line of, being extremely skeptical, thinking it was BS, and not visualizing well. So kind of a through line there. And I'd say that, tell me if this has been a finding for you, that, working, I've clearly not done as much work with cancer patients as you have. I've only worked with a handful, and they're coming in, so often in my world, the way that I'd see clients, here's the one that needs to increase appetite. Here's the one who's not sleeping too well. It's more, and even more so, I see I need this to not become part of my identity. So I still want to maintain everything I'm doing, yet this is just something I'm going to have to deal with over the next couple of months. I'd say it's a through line that's popped up many times, that medical client, that the pain relief client, as someone who would argue that belief is no longer a factor in the hypnosis conversation. We can look at all these amazing research studies involving the brain and neuroscience. You can find 280,000 plus pieces of research on Google Scholar. We've got enough data that we're beyond the belief game, yet still, here's that pain relief, here's that cancer patient that's coming in, and they may be a little skeptical, yet I'd say that's a category that generally we don't need the belief to be effective. Yeah. Here's the question, though. How did coming into that with the skepticism, let's say, inform you with working with these people going through cancer?
Well, it's sort of moving on sort of slightly and sort of jumping around because although I had the skepticism, my background was an IT background, so I'd studied maths and science and computer science and so on. So I had a very inquiring brain and very empirically based. So I'm an evidence-based person. I'm not interested in the BS side of it. Show me the research papers, and I went on from that point of view. One of the later things I did was I was in amongst the first cohort, and I still think there's only about a dozen in the UK to actually study for a master's degree in clinical hypnosis. And I actually had to do my research and decided I wanted to do medical research. And so I've done a lot of studies into those sort of research papers, particularly as far as cancer is concerned. But I found that once I got into working with cancer patients, although you did get a few people that were skeptical, the thing that I noticed that was very different on the belief was, first of all, people that are in that situation are generally quite desperate. So they will clutch at anything that may sort of help them in any way at all. But the other side of it that I found very, very useful was the fact that I see them in that particular role. I see them in the hospital. I see them in the oncology unit. So therefore, because you're considered to be part of the hospital setup, I think you're already given a huge amount of credibility, because it might be the surgeons or the doctors have suggested, oh, why don't you go and see our hypnotherapist? So therefore, you're part of the medical team, the oncology team. So therefore, the idea of being sort of slightly skeptical goes out the window to some extent, because you're another medical professional, if you want to call it that. I mean, that's probably the wrong way of calling it, but in their eyes, you're another one of the team, you're another one of the oncology team. You wouldn't be here unless it was going to be of some use.
Yes. That's beautiful. So what are some of the aspects that you're often working with in that environment?
I work basically with the whole journey. I call it the cancer journey. So I would see people from the initial diagnosis. So that would generally be anxiety, fear, could be fear of death, fear of the treatment, fear of hair falling out with chemotherapy, all those types of things. So very much sort of fear and anxiety and nerves. Quite often you will have to do very quick solutions, very fast interventions, because you'll quite often see people that come in and have a panic attack for something. Whether it's the fact they've got to give blood, have a line put in, go into a scanner, that type of thing. So you'll have a lot of fast interventions for that. Then we work alongside really working on the side effects of whatever treatment they're having at the time, because as you mentioned, things like insomnia, for example, weight gain, are all things that we deal with as hypnotherapists in everyday lives, and all those are quite often relevant as being side effects for chemotherapy and radiotherapy and various other therapies. So we would deal with that type of thing. Pain control, as you mentioned, is quite a common thing. There is interesting research, including my own research, showing that pre- and post-surgical hypnosis can help with the recovery quality, certainly the psychological aspects of it. And then we would work on sort of post-cancer, if you like. So we would work with people that perhaps it's been a bit of an eye-opener to them, so they might want to change other areas of their life in certain ways. We may go on and help people sort of improve their life. I mean, a very good example I had recently was a lady that I found absolutely inspiring. I saw her just over a year ago. I think it was about 15, 16 months ago. She's 31. And she had colon cancer, and initially they told her they didn't think it was too advanced. They were going to do keyhole surgery and remove part of the colon. They got in there and found that it had spread like wildfire. They ended up breaking all her ribs, removing the entire colon, putting in a colostomy bag, all sorts of things. She was in a huge amount of pain when she came round. And they decided because it had spread, she needed chemotherapy instantly as well. She reacted to that, died 4 times and was resuscitated. I was called in still in a hospital bed to work on pain control. She was in quite a mess, but I'm now still working with her. Sort of 15, 16 months later, I'm working with her for improving her triathlon performances.
Wow.
So we go on that side of thing. And then the other side, unfortunately, with some people, the journey has quite a sad end. So we do work To an extent with end-of-life care, that's not an area I do a huge amount with, because we then have specialist counsellors, and also they tend to move into a hospice environment, which is outside, if you like, of the oncology unit. So quite often that is where my remit ends, although we do a little bit of that type of thing. And the other thing that a lot of people forget that we do a huge amount of work with is the partners or the family or the carers.
Yes.
Yeah. Because it has a huge psychological impact on those, sometimes more so.
Yeah, so I love the aspect of just getting the phone call. Is this something you can help with? And 14 years later, that's still a lot of what you do. Let me ask you this, because I know you do work beyond working in that environment, correct?
Yes, I'm a general hypnotherapist.
Right. So how has that? Yeah, how has that specialty? How has that experience helped to inform, let's say, quote, the standard issues that we'd also see as a hypnotist?
Well, I think there's a big crossover, because to an extent, anxiety is anxiety, whether it's anxiety about having a cancer operation or whether it's anxiety about losing your job or relationship issues, it's still anxiety. So you're still going to work with it probably in very similar ways. Again, things like insomnia, nausea, those types of things are all very, very common. So therefore, you can transfer the skills from one to the other, vice versa. So you can transfer the skills from the cancer patients to general patients and vice versa. So really, there's a lot of similarities. I found it didn't impact so much on my hypnotherapy as techniques as such, although over the years I have perfected a lot of techniques and a lot of approaches that I think are very suitable for cancer patients. In particular, a lot of them will have to be fast interventions, and a lot of them, quite often, you will only see a patient perhaps once. They might just perhaps feeling a bit panicky or a bit anxious, or it might be the day they're having their chemotherapy, so they've got a couple of hours to kill, and if you're available, they'll come in and see you and work on something. So it's not something you're necessarily going to do a lot of sessions to work on an issue. So you have to look at, if you like, very, very short, very fast interventions, which I wouldn't necessarily do in my normal practice. I tend to work to a 3 or 4 session protocol. I like to do things like parts work. I do regression to cause if necessary, and so on, which is something that is very little used in the oncology arena. For example, generally, if they're anxious, we know why they're anxious. It's because of the cancer journey they're going through. So going back to finding causal issues and so on are generally pretty irrelevant in that sort of environment.
And I'm smiling over here because I'd share that I've heard some speak in the medical arena concerning hypnosis that no, this model of work doesn't fit. This model of work isn't good there. You can't go to the doctors and start talking about the Elman regression to cause Freudian model of things, because that's not their language. And to hear this dialogue that you just shared is, I think, a message a lot of this community needs to hear, that just like so much of let's put it in a different context, the NLP training that would say that this person's a visual, this person's in time. Everything is state and strategy dependent. So when they're in this mode, that might be that they're visual, but when they're over in this mode, they may be entirely auditory and completely, swap the other way in terms of time. The same way that look at these techniques and to recognize that, well, this environment calls for that. This environment calls for that. And here's this situation where, because I'd imagine as much as you can make the statement that, in the one-to-one session when I'm working with someone over a series of appointments, that quick, rapid style isn't necessary. But I'm sure there's moments where you've pulled that out because you just saw that this is the right way to go right now.
Oh, yeah. And certainly if you get somebody coming into you having a panic attack or extreme anxiety, quite often you'll hit straight off with a very fast intervention, because that gives you a basis to work on. I mean, one of the things that I teach, because I do a lot of mentoring for people to work with cancer patients, and as you know, I do workshops and so on. And one of the big key things, which I would say with any patient or client, not just cancer patients, but the first thing you need to do is stabilize. That to me is always the key word: stabilize. You cannot work with a client or a patient unless they've been stabilized first. There's no use piling in, doing regression or all these fancy techniques if they're sort of anxious and on edge.
Can you elaborate on that? What do you mean by stabilize?
Get them into a place where you can do the work. You don't want them in a heightened, anxious, panicking state. I see people or hypnotherapists that advocate, oh yes, they come through my door, they've got this problem. First thing I do is do regression with them. No, I don't want to. If you like a nice, safe place, get them comfortable. Get the negativity and the stress cleansed. Get rid of that so that we've got a stable, comfortable person to work with. I give an example out like that, if you like. I had somebody approach me for doing some work with an IVF patient. She was having her fourth and last round of IVF, resigned for the fact that she would never become pregnant. But she'd also had a lot of work issues, which were causing her stress and anxiety. And the first thing I said to her was, I said, look, I know you've come for the IVF, that's what you've been recommended to see me for, but you've got these other issues which are stressing you and causing you anxiety. That's going to be having some sort of impact. Let's work on that. Let's get you sound, happy, calm, stress-free. Then we'll work on the other stuff. So we did a couple of sessions on that, and she was remarking out how much better she felt about life and about everything in general, how everybody was commenting on how calm and happy she was looking. And then we said, okay, now we'll work on the IVF stuff. And anyway, she's now got a year-old daughter. So, I think that's quite a good testament to it.
Yeah, I love that. So getting things in motion, recognizing that things are in motion, but at least finding that grounding place that this is where we can launch the work off from.
Yeah, precisely. Just not piling in there sort of willy-nilly without them being in a place where you have a good basis to start with.
Right. Well, I think that even just in terms of just human nature, that communication cycle, that yes, there's one school of thought would say that, oh, they're in the emotional state, you can ride that. It's the problem with that, though, is that you don't necessarily know if that exact emotional state is the emotional state that they're there to help you with. I mean, I'd give the quick example, an extremely generalized version of this. Here's a client who came in for weight loss one time, and suddenly there's the spontaneous ab reaction, and it was triggered by the sound of an ambulance driving by outside. And she's the one calling it out afterwards, and I don't have the entire details to the story, but it triggered this memory of family member in the ambulance, paramedics telling her, you can't ride in the truck with him, you have to follow behind, and he passed away on the travel to the hospital. And to which she was the first one to, she goes, that was so odd. I heard that sound. It brought back this memory, and the tears were there right away. And then she perfectly paused, and remember, she's in the office for weight loss, to go, oh, but I was fatter then than I am now. That's weird. Which, her language. It's to say that, again, we can have that mindset of let's go for this thing, let's get in there, yet the client is coming in for that specific issue. So there is value to stabilizing. Yes, we can use some sort of hypnotic intervention and change to make that happen, to allow this experience that, we can now branch off of this more stabilized place. I love that term now, and do the work from there.
Yeah. And the other thing that sort of changed the subject slightly is interesting. You mentioned about sort of the medical fraternity, the medical model, not liking hypnotherapy, or it doesn't fit with our view of the world. That I find quite fascinating, and have sort of seen it firsthand and been able to change it. I mean, one of the things that I teach people to do in my workshops is learn not the lingo to try and sound false, but certainly in the cancer unit, I make sure that you have a full understanding of the terminology used in treating cancer patients, and you would understand the staging, the grading, and all sorts of other things. And that has sort of two factors as far as I'm concerned. One, if you're then talking to the surgeons, the oncologists, then you appear to know or sound as though you know what you're talking about. So you're gaining a little bit more credibility. And I always say to people, you use academic language. Don't talk about regressions and things like past lives and anything that's airy fairy. Don't even talk about hypnotherapy. Talk about guided relaxation or something like that. Or give it academic sounding technique names. Because they're going to respond much more to that. But I also find that the patients themselves, because you're in the hospital, because you're in the oncology unit, they will come into me, and again, I'm just another cog in their journey. So I'll say, well, what can I do for you? And they say, oh, well, I've got, grade 3, stage 4 breast cancer. I've got a PICC line for my chemotherapy doing all this. And if you look at them blankly, you'll lose all credibility. You'll lose, everything going on. So you're expected to understand all the terminology. You're expected to know what they're going through in their journey. Otherwise, you're going to lose all that credibility. But I also found that that's worked to benefit as well. One, I now find that I can talk to the doctors more and advise them on the use of language. I mean, good example, the old thing that you say, if a nurse says to you, I'm going to give you an injection, you might want to turn away because this might hurt a little bit. You're then giving a nice big powerful suggestion that this will hurt. Whereas if you say, well, you might want to look away and you'll feel a slight sensation, that's far less emotive. And it's going to cause far less distress to the patient. So I make a great deal of doing that type of thing. But it was also interesting to note that the big thing that I found was useful was when I studied my master's, because one of the areas that I found, first of all, having gained a master's, it's something that the doctors will recognise. It's a legitimate university qualification at a high level. So therefore, suddenly, rather than sort of, I've got a certificate in hypnosis, the fact that you've got a master's degree in the subject, that gives you a lot more credibility. And mine was useful because I decided I wanted to make it really difficult for myself when it came to doing my thesis and research. So I decided that, and I was told that I was absolutely mad, and looking back on it, I probably was, but I achieved it. I decided I wanted to do medical research for my thesis, and I ended up doing research into looking at pre-surgical hypnosis and the effects that it had on recovery quality in breast cancer operations. That's what I ended up doing. But what was useful on that was that to actually do the research, I become embedded in the breast cancer multidisciplinary team at the hospital. So therefore, I was invited every week to the team meetings. So I was there, not interacting hugely, but I was there with the oncologists, with the surgeons, with the X-ray people, and so on. Going through all the paperwork, looking at the scans and so on, and discussing treatment regimes for the particular patients. Because I was there, and then I was sort of a face that they started recognising, it started being taken a little more seriously. And then because I was doing my research, and they were actually seeing the results coming back from their patients, and they were seeing how much they were improving after the operation compared to ones in the control group, suddenly I started getting taken a lot more seriously. And we had one surgeon who was very much on side because as a student he'd actually witnessed an operation that had been done under hypnosis without anaesthetic, so he was already a believer anyway. But I found it was very useful in that way to be part of that team with those qualifications, because then you're treated much more of an equal. So rather than being some sort of quack from outside, suddenly you're becoming part of the medical model. And even going on from that, since then, one of my practices is at a GP doctor's surgery. There's about 6 doctors there, and I get most of my patients there are referrals from the GPs themselves. Again, because they've got confidence in me because of the qualifications. I can talk their language academically rather than airy-fairy new age, and also they see the results because I'm seeing their patients in their surgery. So, of course, the patients are then feeding back, so they're seeing the results, and that gives them confidence to send more people to me. And I think that's the way that we need to break down the medical fraternity and the medical model, is to be more academic, to meet them on their own terms, to be well qualified and try and move away from the new age quackery, if you like.
Well, what's beautiful about that is that, the catchphrase that I use for business in terms of breaking into a market is be the expert, be the peer, not the vendor. That you are fully a part of that community. The same as there was a conversation in one of the Facebook groups where someone was asking, how do I get more business clients in terms of working with sales motivation, in terms of working with the mindset towards scaling up a business. And the answer is become a part of that community. That if you're from the outside saying I can do this, without that resume, without that proof that you are part of what they do and you understand what they do, it reeks of being false. And the fact that you're there in the work, again, it breaks past any bit of skepticism that might be there, that clearly, you're the guy who does that. Tell me more about, because we don't have this over here in the U.S., having a master's program. Tell me more about that.
Well, unfortunately, it's pretty much stopped now due to monetary reasons. But the idea, again, hypnotherapy in the UK is pretty much unregulated, as I know it is out there.
Yes.
The only difference we have is that we're not broken into states that have different rules. So
Yeah.
well, at least we have countrywide, so it makes it slightly easier. Hypnotherapy in the UK is not regulated at all. Anybody can call themselves a hypnotherapist and charge money for treating clients, patients, whatever, with no qualifications at all. I know so-called people that have learned off of YouTube and, set up as hypnotherapists. I know people that have got about 5 or 6 jobs, and hypnotherapy purports to be one of them, after a 3-day course. So we do have a lot of problems with that. We do have a lot of self-regulating bodies, but again, unfortunately, they have their own self-interests, and generally they're owned by the training companies themselves. We've tried to legitimise it slightly in the UK, where we have something called the Complementary and Natural Healthcare Council, which was set up by the Department of Health. Unfortunately, the funding then disappeared from it, so they're now a private company. But they still, the idea behind it is they still have a core curriculum for hypnotherapy. They look after all sorts of complementary therapists, but they have a core curriculum of minimum training, minimum standards, minimum hours, and subjects that should be taught. And again, they're only a voluntary organisation, but now what's known holds an accredited register, which if you meet their requirements and you're on their register, the General Medical Council now advise doctors and other healthcare professionals that if they want to refer outside the industry, then the government are satisfied that people on an accredited register are suitable to be referred to. So that gives us a little bit more credibility. Now, from my point of view, I'm actually on the profession-specific board for hypnotherapy on the CNHC. I was actually voted by hypnotherapists in the UK, and I was actually one of the team of 3 responsible for putting the core curriculum together. So at least I've got some input on what I think the minimum sort of training should be. From my background on the masters, the way that went was we had a training company that wanted to train to a high level, and they decided they wanted to make it slightly more academic, and they also wanted to try and make it accredited by university, so it was a genuine university qualification. Eventually they got in with the University of West London, which essentially put a 4.5 year course together, part-time masters. Half of that was psychology, the other half was practical hypnotherapy. There was a lot of essays involved, a lot of practical work involved, but the final 18 months of it, and again, it was overseen and accredited by the university, so it was done at master's level. All the lecturing, a lot of it was done at the university, and there were lots of essays and so on that we had to do. But the final part of it was that you had to do a piece of primary research and a thesis to actually back that up, which was where my breast cancer pre-surgical stuff came into play. Because again, it was because I'd come from the science background, if you like, and I'm a big believer in empirical evidence. To me, rather than just doing a 2 or 3 week diploma and that type of thing, I thought this is the way to go. If I've got a master's degree, all these arguments about, well, I've got a certificate, I've got a diploma, etc., or you're just a quack or whatever, that all goes out the window because I've got a genuine university piece of paper. And the whole course was very empirically evidence based. So again, I found that useful, and I find that it gives me an awful lot of credibility compared to most other hypnotherapists.
Yeah,
unfortunately, due to monetary reasons,
right. Yeah, that's what I was going to get at.
Yeah, unfortunately, due to monetary reasons, the company that was accredited by the university sort of fell out with them. The owner since passed away anyway, and it's fragmented a little bit. So unfortunately, the master's degree has now been pulled. It's no longer available to do. So we're stuck with only a handful of us at the moment. But hopefully somebody else will revive it. I believe there's another university that are looking at doing a research-based master's degree in hypnosis, which again can only be a good thing.
I mean, that's an unfortunate thing that it comes down at times to the funding for such a program, and we are still a very small community. That there's a former guest, I'll generalize the story here, the former guest who was doing an amazing amount of neuroscience research involving hypnosis, and just suddenly the university goes, yep, we don't have the funds for that anymore. But to have the basis of this, of all things, I flash back to somehow two random people that I met separately of each other. Local university at one point had a whole design your master's thesis program. And of course, they did theirs in circus history, like you do. But such a program does exist at times that really it's taking pioneers. And I need to get Adam Eason on here at some point because I know he's got something of that style possibly in the works.
Adam I know very well. He is actually got a tie-up with the Royal Society of Medicine and also Bournemouth University, and it's actually him that's involved in setting up the Masters in Hypnosis research, as far as I'm aware.
Beautiful, beautiful. So looking at the nature of bouncing back and forth between these two different styles of work, one in the cancer hospital environment and then the other working with primary clients, working with the sort of general issues we would face, what would you say are those things you see the most of?
Nowadays, I wouldn't say I mean, it used to be the same as everybody else. Now, number one, I guess, is still anxiety and depression-based things, and that's mostly because that's what the GP send me. Mm-hmm. I think particularly in the GP practice that I'm resident in, I think I'm the sort of person that the doctors, or two or three of them in particular, it's a case of, okay, yeah, they're depressed, they're anxious, we've given them all these drugs, they're still coming and complaining to us, nothing's making a difference. Why don't you go and try hypnotherapy? So I probably get the most is that type of thing. I'd get less weight loss and smoking now than I used to, I think, probably because I'm probably a little bit more expensive, well, certainly more expensive than a lot of other hypnotherapists in the area. So I tend to find I get a lot of referrals from other hypnotherapists and even psychologists and psychiatrists that I tend to find now that I get the more unusual cases or ones that other people are not willing to take on. Even quite surprisingly, it's one area that I've always been taught is contraindicated with hypnotherapy. But I've done some work with psychotics, for example, and that they've actually been referred to me by their psychiatrists, which is quite interesting. So, despite the fact that we might think it's contraindicated, there are certain psychiatrists that are quite happy for us to get involved. Now, obviously, it's an area you need to tread very carefully with. Yes. With techniques, because otherwise you're going to cause a lot more problems. But it is an area I've done work with. And another area I tend to do quite a lot of work with, and that again is all GP referrals because they're seeing results. I seem to get a lot of borderline personality disorder work for sort of patients. So a bit of everything, but I relish the more challenging things anyway.
So what would you say that difference is, though, aside from price, why you're not doing so many, let's say, smoking and weight loss, mindful of the fact that we as the practitioner, we get to choose the things we work with. We get to choose those specialties. What is it that draws you to those, quote, more challenging issues, would you say?
I think it is, again, because I like to push myself. I still want to learn more, push myself. And to be honest, I mean, okay, yes, you make money, decent money out of quit smoking and things like that. But frankly, I find a lot of that quite boring. I want things that are going to challenge me as a therapist as well, that I can learn from, that expand and grow from, not only as well as helping the client.
Yeah. Beautiful. So in working with people, I know that we were chatting yesterday about the mindset of streamlining the process, becoming much more direct, building some systems. What's some of that thinking that you've put into the work over the years in doing that?
Well, again, it's doing the masters, for example. You're training for 4.5 years, so you're looking at many different styles of hypnotherapy and allied techniques. So, for example, you're not just looking at Ericksonian hypnosis. You're looking at traditional hypnosis. You're looking at Ericksonian. You're looking at solution focused. You're looking at psychoanalytical. So, and you're looking at NLP, EMDR. You're looking at CBT. So, you're taught all these backgrounds anyway. So rather than just being very limited to one sort of approach of this is how you do it, you've got a whole armory of approaches, sometimes completely different and completely polar opposites for you to choose from. There isn't necessarily a right or a wrong one. It's which one are you going to use, or which one is your preference, or which one do you think has the best fit for the client. From then, I've gone on to train with a lot of other people. Conferences are always a good eye-opener, because even if you just go and see somebody for an hour or two, you might get the odd little nugget here and there that you think, actually, I never thought of that, or yeah, I could incorporate that particular phrase in what I do. I can see how valuable that is. So again, I've done that, train with a lot of different people. a lot of people that I've trained with, again, are quite very effective, but also quite blinkered that, my way is the way that you should do things. And I've always been a little bit anti that, to the extent of, because, for example, and I'm not going to name names, but there's a couple of people that I've trained with, and one in particular, they said, right, you do it exactly like this. You don't change any word, any phrase, it's done it. This is how it works. And I've gone back and said, but I now do this and do this. And no, you can't. Yeah, but I do. And it works for me.
Right. Yeah.
So what I've done over the years is basically, and particularly a lot of it's come from my oncology work. You do what works. You get more experience, so therefore you become more experienced. You tend to have more of a feel for what's going to work with a particular client in front of you. You find that the techniques that you've learned, perhaps you then combine them with other techniques because they've then become more powerful, or they become quicker to use, or more effective. And I found over the years that I've put a particular protocol, a particular way of working together, that to me works with the majority of issues that I'm likely to come across, with the majority of type of clients that I will come across. And I know of no other hypnotherapist that does it how I do. So that's why I've decided to perhaps, one of my other workshops is now, which sort of is both good and bad, because as I mentioned, I hate the idea of, people saying you must do it exactly this way, because I think that's limiting. But I've had so many people over the years when I'm mentoring them sort of, well, teach me how you do it. So now I've decided, okay, I'll teach everybody that wants to know how I do it, but with the proviso that this isn't the only way of doing it. This is how it works for me, and this is why I believe it works for me, because I do this because I do this because, and I'm a great one of sort of having a plan B, C, and D. Some of the things I always tell sort of newer hypnotherapists about, they say, well, give us some tips. And I always say, well, always have a plan B, C, and D, so that if something doesn't work, you've got something you can seamlessly go on to. Whatever happens, you must ensure that the client thinks that what was meant to happen, because otherwise you're going to lose rapport, you're going to lose confidence and credibility. So you've got to have both of those things in place anyway. And then basically just go with the flow from there. And also, particularly in my pre-talk, and even the way that I style things such as ratifiers and the way that I work, I try and get to a situation where the client has no wriggle room at all. They have nowhere to go apart from where I want them to go. So to the extent that a ratifier cannot fail. Because yes, you might think, oh, that has failed, but in the client's eyes, it hasn't. That's what was meant to happen. So they've got no way of getting out of it. I've got ways of doing parts work, which is quite authoritarian. So there's none of this, let's take forever negotiating parts. This is what's going to happen.
Nice.
And it does happen. Again, if you get the pre-talk exactly right, they've got nowhere to go apart from where you want them to go. And that's a big part of sort of the approaches and the protocols that I've put together. It's basically, it's so defined that the client has no choice but to go this way. You're guiding them exactly where you want to guide them, but yet they think that is natural, normal, and that's naturally happening.
And what's great about that is, I can give you the example of yesterday was a day where every client I was seeing was, I got a new promotion at work and I have a fear of public speaking. And not for the sake of novelty, every session was different. Even from the different style. I'd even ask you if you explain hypnosis differently in the two different environments you tend to work.
Not hugely. I must admit, in the hospital environment, they get a lot less explanation.
Yes.
Not because, the main reasons is time. If I'm seeing a client privately, generally my first session would be 90 minutes or up to 90 minutes. Sessions after that, generally an hour. And obviously I then have time for writing up, analysing, reviewing and so on. Whereas hospital appointments are 45 to 50 minutes tops, including everything. And that's dictated by the hospital. Obviously you're much, much more limited in that sort of environment. So you do explain it differently, but mainly in a more sparse way, if you like.
Yeah, beautiful. So where could people find out more about your work online?
Well, there's two things. I've got a website which currently isn't working because it got hacked. It got hacked, and then
well, this is where we reveal to the audience that we are recording on December 4th, and through the wonders of batch production, this is coming out January 10th. So you've got a month and 6 days to figure that crap out.
Yeah, except I'm going to be in the Caribbean for a couple.
Oh, even better.
Yeah, so there will be a website which is releasehypnotherapy.com. But I put a lot of research articles actually on my Facebook page, which is also Release Hypnotherapy. So if they look for Release Hypnotherapy as a Facebook page, I put a lot of research articles on that, newspaper articles, anything I can find that is relevant will go up onto there. So it's a useful resource for people to actually use as a hypnotherapist.
Outstanding. It's been wonderful having you on here, Garry.
Yeah, thanks very much for having me. And again, I hope to see you. Well, I guess next time will be stateside, because as you know, more and more, I tend to be spending more and more time at conferences and teaching over there as well as over here.
Jason Linett here once again, and as always, thank you for sharing this online, leaving your reviews. Head over to the show notes at worksmarthypnosis.com to get the links to Garry's website, as well as his HypnoThoughts Live 2019 training, and also check out worksmartbusiness.com. Before the book launch, that's how you can get a free copy of it digitally. After the launch, that'll likely redirect over to the page on Amazon, helping you to work smart on your business and your hypnosis and many other work smart projects coming down the pipeline rather soon. I'm Jason Linett. See you soon.
Thanks for listening to the Work Smart Hypnosis podcast at worksmarthypnosis.com.
Hey, it's Jason here, and I want you to be the first to find out as we upload new content here online. So do this right now. Click subscribe right next to this video, and you will be the first to find out as I share further resources, further downloads, and other really cool things to come your way. See you soon.